Hello, advanced students. This is Tracy, and I want to do a little bit of recapping on some of the information that we talked about in class on Monday. And I'd like to begin talking about Chapter 21 with cancer development. And when we were talking about cancer development, we did take the time to go through how normal cells go through the cell cycle. And when we think about the cell cycle and we're talking about cellular division, we're talking about mitosis. And mitosis makes one cell divide into two new cells that are identical to one another. And so those are going to be called your daughter cells. The steps of entering and completing the cell cycle are tightly controlled, and that's really related to cellular regulation. And we talked about how cellular regulation starts, how it stops. And so we have those oncogenes or cyclings that start the cell or allow the cell to go into the cell cycle. Most of the time the cell spends much of its life in the interphase, and then it moves into G1, which G1 again is that period of growth and normal metabolic roles. It is where DNA is starting to think about getting ready for division. Really in the G1 phase, the cell is kind of getting ready for division. So the cell's taking on increased nutrients, it's building up more energy, and then it will move into the S phase, or the synthesis phase, and that is where we have that doubling or replication of DNA. From there, it's going to move into G2, and G2 is growth and preparation for mitosis. So with G2, the cell makes important proteins that are going to be utilized during cellular division. After it moves out of G2, it's going to move into the mitotic phase. And with the mitotic phase, again, that's where we have the prophase, metaphase, anaphase, and telophase. And so during prophase, that's where DNA condenses, attaches to the microtubules of the centromes, and mitotic spindles start to form. So it's really kind of organizing and getting ready for the cell division. From the prophase, it moves into metaphase, oftentimes or sometimes referred to as prometaphase. And during the metaphase time, the nuclear envelope fragments or it breaks apart. So that membrane that's surrounding the nucleus breaks apart. Those microtubules are attaching to the cytochromes, and that's getting ready to kind of pull apart the DNA so that it can again move to each end of the new cells. Remember, metaphase refers to middle, and so during metaphase there's that plate of chromatids, and that's the DNA lining up kind of in the middle of the cell. During anaphase, the chromatids separate and we get equal DNA in those daughter cells. And then lastly, we have the telophase, and in the telophase, that's where the new cells are really formed. That original cell begins to elongate and it forms a cleavage furrow, and it's kind of like where the cell pinches off and it makes those two daughter cells that are identical. And so remember, that is normal cellular division, the normal cell cycle, and a huge component of growth or of cellular regulation. The next thing we talked about was cell growth, and we talked about the two terms hypertrophy and hyperplasia. And with hypertrophy, again, remember hypertrophy is related to those cardiac cells because we're only born with so many cells, and once we leave fetal life, we have as many cardiac cells as we're going to have. And so those cardiac cells only have the opportunity to grow in size. And then we also have hyperplasia, and hyperplasia refers to the making of new cells, and we increase in tissue size by making new cells, not our cells actually growing up or growing larger. We didn't talk about neoplasia, but neoplasia is any new or continued cellular growth. And with neoplasia, it's not needed for normal development or replacement of dead or damaged tissue. And then that's when we get into the benign and cancerous types of tissue growth. And we did spend a great deal of time talking about the differences between what is benign and what is malignant cell growth. And remember, benign is really harmless. A lot of times it doesn't require any intervention. And malignancy is going to be those cancerous cells. And if we don't do something about malignant tissues, it could eventually lead in death. So remember when we just talked about benign, we talked about skin tags, moles, fibroid tumors, polyps. We had lots of different information up on the board. And so those are going to be things that really, they're not going to cause us a lot of harm, but sometimes they can just be sort of a nuisance. So when we talk about the biology of normal cells, we talked about normal cells having a specific morphology, and with specific morphology that is a distinct and recognizable appearance, shape, and size. A smaller nuclear to cytoplasmic ratio, and that just means that the nucleus, or the middle of the cell, is really relatively small compared to the size of the rest of the cell. It has differentiated functions. And so remember with that, every normal cell has a specific function to perform, and then that specific function is going to contribute to the whole body functioning. So you could think about liver cells that make bile, your red blood cells with hemoglobin, skin cells making keratin. So each cell has its own job, it has its own duty, and we really need all of those duties carried out in order to make our body function as a whole unit. Normal cells also have tight adherence. So normal cells make proteins that protrude from their membranes, allowing cells to bind closely and tightly together. The only exception that when we think about tight adherence, the only exception to that rule is going to be the blood cells. And that's because we know that our blood cells are meant to travel through our bloodstream. But otherwise, cells have that tight adherence and stick tightly together. They also have a non-migratory feature, and so normal cells do not wander throughout the body, again, with the exception of blood cells. Cellular regulation is considered the orderly and well-regulated growth of cells. And really normal cells undergo mitosis for two reasons. And we did discuss these in class. So they go for two reasons. One, to develop normal tissue, and two, to replace lost or damaged normal tissue. And we really don't want cells to continue into this cell cycle, because if we don't have an orderly and well-regulated growth, then we're going to end up with benign type tumors or possibly cancerous type tumors. And remember when we talked about the cell cycle, oncogenes produce cyclins, and cyclins are responsible for the promotion of cellular division. So when cyclins are activated, they allow that cell to leave G0 and go into G1 and the rest of the cell cycle. We also talked about suppressor genes, and suppressor genes are the ones that control the amount of cyclins present. So suppressor genes tell our body to reproduce cells only when they're needed, because we don't want an overgrowth of cells. Mitosis, so again, that's the division of one parent cell into two identical daughter cells. Contact inhibition is cellular regulation that stops further rounds of cellular division when the dividing cell is completely surrounded and touched by other cells. So when you think of contact inhibition, remember it's just direct contact on all surfaces. And so when you think about if you get a cut, we're going to produce new cells in order to heal that cut and to heal that tissue that we've damaged. But once those cells have touched another cell and they're surrounded on every side, then those cells are going to stop growing. We discussed what apoptosis is, and remember apoptosis is programmed cellular death. And so that really just helps ensure that each organ has an adequate number of cells at their functional peak. We talked about red blood cells having a 120-day lifespan. There's the white blood cells are 12 to 18 hours. And so that's the really big importance behind apoptosis. And then lastly, normal cells have normal chromosome numbers. And we did determine that 23 pairs of chromosomes is normal. So benign tumors, benign tumor cells, they're just growing in the wrong place at the wrong time. And so we talked about the benign tumors being harmless. Benign tumor cells can result in a small problem of cellular regulation, but it's not that it's causing any type of destruction to the patient. It's not going to cause them any harm. And so listed out up here on your screen are a couple of different types of benign tumor cells. So this slide lists out the features of those benign tumor cells. And truly, if you look at these and compare these to the biology of the normal cell, they really have pretty much the same thing, other than the fact that they're growing at the wrong place or the wrong time. So with orderly growth, even though it's not needed, it goes above and beyond the appropriate time. So it does have an orderly growth, but I wouldn't say that it's not functional growth because it's going above and beyond the purpose. But the one thing, remember, with benign tumors, it doesn't invade any other tissues. And so that's one difference between the benign and normal cells. And then lastly, we have our cancer or malignant cells. And when we think about cancer or malignant cells, they're abnormal cells. They can cause serious to fatal effects if we don't have some type of intervention. When you think of cancer cells, really think of something that's not good. There's no useful purpose for it. There's no reason for them to be in our body. And unfortunately, if we do have them in our body, then it's going to cause harm to our other tissues. So features of the malignant cells: anaplasia. So remember, with anaplasia, it's loss of specific appearance of the parent cell. So when these cells go through mitosis and we make daughter cells, those daughter cells end up not looking anything like the parent cell. And remember, when I talked about normal cellular regulation and normal cell mitosis, those daughter cells are identical to the parent cell. However, with cancerous malignancies, they have anaplasia, and so there's loss of specific appearance. So those daughter cells are not looking anything like the cell that they originated from. And they change in appearance the more times they undergo mitosis. So the longer they're given to continue to grow rapidly and multiply, the more loss of the look of the parent cell there's going to be. There's a large nucleus to cytoplasmic ratio. So again, that nucleus is getting much larger, taking up a lot more of that cellular space. The specific function is lost. So again, there's absolutely no useful purpose of cancerous cells. Migration can occur. So cancer cells don't bind tightly together. They don't hold on to one another. They allow cells to spread to other areas of the body. And when we have migration occurring, as you can see by the screen, it says that we have metastasis. And so remember, metastasis is spreading to other parts of the body. Contact inhibition does not occur because of loss of cellular regulation. So these malignant cells are going to be allowed to continue to grow and grow. Rapid or continuous cell division. So that cellular division is persistent. It continues to go back into that cell cycle, continues to produce and multiply. They don't respond to apoptosis, so these cells are not going to die either. And then lastly, abnormal number of chromosomes, so aneuploidy. And remember, when we think about aneuploidy, it can be that we have added chromosomes, we have subtracted chromosomes, or it might be the simple possibility that some chromosomes have broken off, but they have definitely lost their features. To undergo cancer development, really our body has to go through this malignant transformation. And with the malignant transformation, it kind of goes through some steps that are listed out up here. So carcinogenesis really is changing of normal cells into a cancer cell. Malignant transformation occurs through loss of cellular regulation. And once we have that loss of cellular regulation, it leads into these steps: initiation, promotion, progression, and then finally metastasis. So initiation is really the first step in carcinogenesis. And during initiation, oncogenes turn on excessively, or stimulate excessively, overstimulate the cell in the cell cycle. And remember, the oncogenes are those proteins or cyclins that promote cells to enter into and complete cellular division. So with those oncogenes being overly expressed or highly turned on, the suppressor genes are lost or damaged, and so we don't have that suppressor function. We don't have something telling those cells to stop going through cellular division. Initiation is a change in gene expression caused by anything that can penetrate a cell and get into the nucleus and result in a mutation of the DNA. With initiation, there is an irreversible event that can lead to cancer if it is allowed to continue. So really, if growth conditions are just right, one cancer cell can lead to metastatic disease, which can eventually lead to death of our patients. And when we think about growing conditions and things being just right, we talked about some things that are needed. And so, it could be that we have that genetic risk factors. We have an exposure to carcinogens, and maybe it is the sun, maybe it is smoking, alcohol, poor diet. So some of those types of things, anything chemical, physical that might put us at increased risk for cancer development. And we also talked about some of those viral agents. So we talked about hepatitis B and C. Epstein-Barr is another one. And we also talked about HPV, or the human papillomavirus. Once it moves through initiation, then we have this period of promotion and progression. And with promotion, there's enhanced growth of the initiated cell. And with promotion, these cells produce substances known as promoters. And so remember, when you think of promotion, think of moving up, moving on, continued growth. With progression, that's the continued change of a cancer, making it more malignant over time. So during that progression period, that cell is going to move further and further away from looking like its normal parent cell. After cancer cells have grown to the tumor or detectable stage, other events really kind of have to occur in order for that cancer to become a health problem. And so, during progression, that tumor has to kind of go through some steps of its own in order for metastasis to occur. And so when we talked about that in class, we talked about a picture that's in your book, and it goes through the steps of metastasis. And so with those steps of metastasis, that tumor has to go through tumor vascularization. And remember, the tumor vascularization is really that tumor developing its own blood supply to ensure that it can continue to have nourishment and continue to grow. Once we have tumor vascularization, it will move into blood vessel penetration. And that's kind of the initial step in metastasis. And so that tumor will continue to divide and change so that it continues to have fewer and fewer normal cells within the tumor. Blood vessel penetration allows for cancer cells to break off from that main tumor and get into the bloodstream, get into the lymphatic system, and travel around the body. And while those cells travel around the body, eventually they will come to a period of arrest and invasion. And during arrest and invasion, this is where we have those secondary tumors or metastatic cancer developing. So cancer cells will kind of clump up and invade new tissues. And with the clumping up and invasion of new tissues, again, our body has to go on through this whole process of good conditions at that new site for cancer cells to continue to grow. And then the process continues unless we seek some type of treatment. When we think about cancer classifications, again, there's several different things and several different ways to think about a cancer tumor. And when we think about grading, really grading is needed because some cancers are more malignant and vary in aggressiveness and sensitivity to treatment. So when we think about grading, grading is really how malignant that cancer is. So it's also useful to determine prognosis and therapy options, and then again to evaluate the result of what treatment option or what management we're using to help control this cancer. The ploidy looks at chromosomal abnormalities. So ploidy is the description of cancer cells by chromosome number. And with those chromosome numbers, it wants to look at what is the appearance? What do they look like? Are they broken? Are they lost? Are they added? So ploidy is really looking at chromosomes. And it does talk about the Philadelphia test using that really looks at chromosomal abnormalities and is quite useful in chronic myelogenous leukemia. Staging is another way we classify cancer, and when you think about staging, again, we stage them 3 different ways. So we talk about clinical staging, surgical staging, and pathological staging. And staging really determines the exact location of the cancer. It looks at the degree of metastasis at diagnosis. And staging can also influence selection of what type of therapies we're going to use to manage this cancer. When we think about clinical staging assesses the patient's clinical manifestations. So what does the patient present with? What are their complaints? Clinical staging can also be useful to help evaluate tumor size and possible metastasis. Because when we think about cancer spreading, we may have localized complaints, but then we also might have complaints elsewhere. Surgical staging assesses the tumor size, the number, the sites, and the spread of cancer by inspection at surgery. Pathological staging is the most definitive. And when we think about pathologic staging, again, that's looking at that tumor at the cellular level. And it is the most definitive. And we can evaluate those tissues after surgery. So we take a biopsy of the tissue, send it to pathology, and then come up with those pathologic reports that talk about what the cancer is like, how aggressive it is, what treatment options might be available. Another thing when we think about cancer classification is the tumor node and metastasis. And you can refer to your book for descriptions of each of those. But when you think about the tumor, it's wondering the size of the tumor, how many tumors there may be. Lymph nodes are the nodal aspect of that wants to know if there's any nodes involved or several different lymph nodes involved. And then metastasis is either yes or no, that there's no metastasis present, or that yes, there has been metastasis noted to different sites. So we have a secondary tumor, something that has broken off from primary site and has now metastasized to other parts of the body. When we look at doubling time and the mitotic index, the doubling time is really how fast that tumor doubles in size. And your mitotic index is the percent of actively dividing cells in the tumor. So there's several different things to take into consideration when we are talking about cancer classifications, when we get ready to set up treatment options and really kind of get into the nitty-gritty of what kind of cancer our patients have and how severe it is. Some of the etiology and genetic risk factors. So again, we talk about oncogene activation, and really the oncogene activation is the main mechanism of carcinogenesis. So it's that turned on again or overexpressed oncogene, and we see this once a mutation has occurred in the cell's DNA. When we think about chemical, physical, and viral carcinogenesis, the chemical is exposure to known drugs, chemicals, and other products in life. With the physical carcinogenesis, that's going to be radiation, so it could be ionizing radiation, it could be due to ultraviolet rays, or really chronic irritation. So if you have a patient that has a scar and that's being chronically irritated over time, or we have had chronic irritation, say from cigarette smoking, from alcohol abuse, those types of things, And then viral carcinogenesis is that a virus has infected the body and that has caused a breakage in DNA strands which cause activation of the oncogene. These viruses also damage that suppressor gene, and ones that we had talked about in class were the HPV, hepatitis B and C, and then I did also mention the Epstein-Barr. So how do we stop it? How do we prevent it? When we think about primary prevention, these are ways that we need to educate our patients on. So avoidance of those known potential carcinogens. So using sunscreen, wearing hats, skin protection, avoiding tobacco. If you have exposure to carcinogens at work, then using that personal protective equipment that is made available to you. Modifying associated factors, so modifying that diet, get more whole grains, limit the number of sexual partners, practice safe sex methodologies, removal of at-risk tissues, so getting rid of those moles, polyps, fibroid tumors, any of those types of things. Chemoprevention is really a strategy that uses drugs, chemicals, natural nutrients, or other substances that will help disrupt the steps necessary for cancer development. And so with chemoprevention, thinking about aspirin and Celebrex to help decrease the risk of colon cancer. We talked about tamoxifen with utilization and prevention of breast cancer. And lycoprin is also utilized to help prevent prostate cancer. And lastly on this slide, vaccinations. So vaccinations, there's not really very many, but we did talk about the HPV, and I definitely think that you'll be seeing more and more throughout your lifetime. Secondary prevention, again, secondary prevention means screening. And when we're talking about screenings, again, screenings have to be valid and they have to be reliable. These regular screenings don't stop cancer from developing, but they can greatly decrease the number of deaths related to cancer. So it all goes back to that early intervention, early diagnosis, early treatment, and then better outcomes. With genetic screenings, screenings can help a person try to help modify their lifestyle, can tell these patients that are going to be at risk for developing different types of cancer. Again, it doesn't diagnose, but it can definitely help people be more cognizant of their own body. So we talked about the BRCA1 and 2. We also talked about the APC and as well as the MLH1 and 2 associated with colon cancer. So those are going to be really related back to your genetic screenings. When we talked about regular screenings, remember your yearly mammography once we're over 40. Unless, of course, something has been abnormal. Yearly breast exams over 40, colonoscopies at 50, and then every 10 years unless we have at-risk tissues. Yearly fecal occult, and then digital rectal exams for men over the age of 50 to help detect early detection of prostate cancer. We're going to spend some time talking about the tertiary care, or things that are associated with cancer and during the treatment of cancer. And so we'll kind of spend some time talking about how we're going to care for our patients with cancer. So care of patients with cancer, we know that cancer is really a holistic disease that can affect a person's entire self. When we talk about cancer, remember the C means comfort. The A is altered body image. N is nutrition. C, chemotherapy, radiation, or surgery. E is to evaluate the response to medications. And R is respite care for the caretakers. And this moves into chapter 22 of your Ignatius MedSurg book. And we talked about when you hear the word or diagnosis of cancer, what do you think? And we wrote several different things out on the board. We talked about pain, suffering, death, anxiety, body image, hospice, impaired family processes. So we talked about a lot of different things. So providing care to patients with cancer and their family is really complex and very challenging. So what we can do is try to help prevent some of these disease-related consequences of cancer, or protect our patients from having harmful and devastating effects of these consequences of cancer. So when we talked about reduced immune and blood producing functions, a lot of times with leukemia, bone marrow cancers, any type of lymphoma, it's also associated as side effects of chemotherapy, radiation. So with reduced immunity, we have a much higher risk for infection. And with reduced blood producing function, that's reduced red blood cells, it's reduced platelets. So with reduced red blood cells, we can associate that with anemia. And with anemia, we can, kind of think of weakness, shortness of breath, fatigue, inability to carry out ADLs, pallor and color. And then with thrombocytopenia, or decreased platelets, we have to think about impaired clotting, and so our patients are going to be at a much higher risk for bleeding. With the altered GI function, we can think about obstruction or compression anywhere on the GI tract. We can think about some of the cancers or treatments that will decrease the ability to absorb nutrients, and as well as eliminate waste. Because again, it's from mouth to it's from oral intake to elimination. Also, things to consider are the tumors that our bodies may be growing if we have cancer. Those tumors increase metabolic rates. And this can be bad because your patients are also, are usually fatigued from having chemotherapy, radiation. So if we have these tumors that are speeding up metabolic demands, our patients are going to be quite fatigued, and maybe they can't prepare their food. If we have tumors that invade the liver, that can interrupt metabolic function. We can build up wastes, and those can lead to death. Anorexia is quite common, and our patients aren't getting enough food or nutrients to meet the needs of their body's demands. Your book makes reference to cachexia, which is body wasting with increased catabolism. So those are those people that are extremely underweight. Anorexia and cachexia oftentimes are side effects of chemotherapy, because chemotherapy can cause decreased appetite. Our patients don't really want to eat. So we definitely need to think about some nutritional support, having them take a high protein, high carb diet. And remember, it's not going to be a one diet fits all. We're going to have to really work with these patients to try to help meet their needs and demands. Motor and sensory functions. When we have motor and sensory deficits, cancer can invade bones or compress nerves. If we have cancers that are invading bones become much thinner, and that puts our patients at an increased risk for pathologic fractures, increased pain, increased risk of hypercalcemia. And we did talk about hypercalcemia as being an oncology emergency. And with elevated calcium, we see muscle weakness, bone pain, nausea, vomiting, confusion, decreased DTRs. We can also have decreased mobility because we have lost the ability of our weight-bearing bones. Oftentimes patients will report having like a really foggy brain, or chemo fog, and that's due to that inflammatory process that chemotherapy can put on our patients' brains. And so it's just really, trying to protect these patients from harm. And then decreased respiratory functions. And with decreased respiratory functions, it could be that we have an obstruction from the tumor, so an obstruction in our airway. We have decreased lung capacity with lung cancers. Might be related to the anemia, and we don't have that oxygen carrying capability. And some of those things that we might see are going to be dyspnea and hypoxia. When we think about treatment for our patients with cancer, we talked about surgery, and the surgical piece is really trying to be pulled forward from basic concepts. And so when we are thinking of surgery, remember what each of these surgeries mean. So we went through and talked about what prophylaxis is: diagnosis, curing, controlling, palliation. And remember, if our patients have to go through surgery, there's going to be side effects that the normal surgical patient won't have. So unlike normal surgery, cancer surgery often involves the loss of a body part or loss of functionality. These surgeries can be very scarring, they can cause disfigurements, and patients are going to be wondering about their survival rates after surgery. So consider your patient-centered care. Think about how you can help your patients adjust to and adapt to the changes that they have undergone during surgery. With radiation therapy, really the purpose of radiation therapy for cancer is to destroy cancer cells, have minimal damaging effects on the surrounding normal cells, and then lastly, to maintain a safe environment. So when we talk about radiation therapy, we talk about it being a local treatment. And with it being a local treatment, the effects of radiation are seen only on tissues within the radiation path. And so it differs from chemotherapy because, again, we talked that chemotherapy is systemic and radiation is going to be local. Most radiation therapy for cancer is ionizing radiation. Gamma rays are used most commonly for radiation therapy because of their ability to deeply penetrate tissues.